Yes, I just wanted to ensure that you all were hearing.
Dr. Singh, thanks.
Sorry about that. Go ahead, Cindy.
Okay, perfect. Perfect. Yes. So I'm just going to quickly go over today's agenda. We're going to begin the day with an assessment poll, just kind of trying to assess knowledge level based on information provided yesterday. And then we're going to go into a presentation by Dr. Omar. He's going to be presenting on monitoring and efficacy. Then Dr. Hortensia will be presenting on STI, hepatitis, viral management in the context of PrEP. Dr. Shante will be presenting on new modalities for HIV prevention and the future of PrEP. And then we could end. Sorry, someone's mic on? And then we're going to end with question and answers, whatever questions you may have, and a quick post assessment of what was gained on day 2. Right, so we should end today by 11 a.m. if we could keep things rolling. So I'm just going to quickly pass things over to Dr. Shante, and we go from there.
Thank you very much, Cindy. Good morning, everyone. So the assessment today is actually a live poll. I think you would notice that this has replaced the reflection, and so yesterday at the end of the session, the organizers briefed and acknowledged that a good recap was done by Cindy yesterday afternoon. And so we felt that a poll would be a really good approach to take this morning. As Cindy says, and the poll is up live, you can go ahead and start responding. It will give us an idea as to, what are the concepts that were well received. Is there any specific gap that we need to pay attention to? We have today and we have tomorrow, so we're able to address those adequately before the end of the training. So please go ahead. Cindy, can you see the poll?
Yes, I can.
Thank you. So please go ahead. Take your time. We have about 15 minutes to do this. I'd say 10 because we're a little bit behind time already.
So Shantis, good morning. Just to remember that the results are confidential, so nobody will identify who is replying. And don't worry if some question, or if you don't know some question, because all the questions will be addressed today also.
Oh, absolutely. Thank you, Omar, for that reminder. And it's anonymous. We don't know who is responding how.
Okay.
Yeah, I still have no audio. I don't know what's going on. All right, just if anything, I don't have no audio. Oh.
You said that you can't hear, Sandra. We can hear you speak. Please go ahead and respond to the poll. I think this will be really important for us to understand what are the gaps, how our presenters can address those gaps once we identify them. So please go ahead. I see the response rate is somewhat low. We have a few minutes more. So if you haven't started as yet, now would be a good time to start responding to some of the questions.
Some of these questions don't factor in the socioeconomic background of the individuals clinicians are dealing with. And over the years, and I've done this for 15 years, clinicians sometimes don't even have a working knowledge of sexual reproductive issues for key populations, and so can answer many of the concerns around their sexual habits, or the clinicians then just skirt around the issue because they're not sure what to see. Just making an observation.
Thank you, Caleb. Okay, so Dr. Omar, you think we're good to move on? Cindy?
Okay for me?
I'd say about 1 minute, 1 minute
One-
for whoever is finishing up.
Okay, thank you, Cindy.
There's so many logistics questions to these, to the 10 questions I have, but since it's an NAC matter, I'll leave my question after these training things are done.
Thank you, Caleb. Yes, the question were intended for the question were intended for providers. Sorry for that. This was the audience we thought that will be participating, but everybody is open to question, to replying, and if the civil society is aware of what are the element that will be critical for the eligibility and maintain the people on PrEP is also a good opportunity for share this information with civil society. So please send your comment also by email if you want, or in the chat, and we can try to add in the following trainings also this point of view.
I've seen what happens to my comments, so I will speak nothing of logistics, only the medical PrEP questions.
All right, I believe we could safely move on. I'm not sure if we want to go over the answers of that poll, or could you kindly inform me of such, Dr. Shanti?
I believe that to Dr. Omar and Dr. Hortensia, do we do the results of the poll now, or do we leave it for later this afternoon?
I think that it will be better to present tomorrow the result of today and tomorrow, because I understand that today many questions will be not well answered, because the purpose of is to understand what is the pre-test knowledge, and we hope that we will improve that with with today and with tomorrow. So maybe tomorrow we will can see this comparison, and if not, there are not many difference on that, we can work in the question that were not clear.
Sounds good. Well, the floor is yours, Dr. Omar. You could go ahead.
Thank you very much. Thank you, everybody, for sharing the opportunity today. I will try to have better management of my screen today, because it was not very easy yesterday with another computer. Fortunately, I have my computer fixed, and I think that you are seeing clear. Everybody's seeing, isn't it?
No, we don't see your.
Okay, let's try again. Screening to share. You should.
Now we can.
Oh, well. The last opportunity, let me try again. Stop sharing here. There? No?
Not yet. It popped up briefly.
Oh my gosh. Hortensia, can you share for me, please? Because I don't know what is the problem with this computer.
Can you send me the presentation?
Sorry for that. Is in your email now. I will continue tracking.
We could see it now.
Okay, perfect. If you can see, you can continue seeing.
Yes.
My laser phone. Perfect.
Yes.
Thank you very much. Sorry for that again. So today we will try to review what is needed for start treatment with PrEP and what we will do during the follow-up. So as you know, the PrEP is a process, it's a cascade. So we identify individuals and then we determine if the individual is eligible. We start PrEP, we maintain on PrEP the people and trying to support the adherence and continue the people in PrEP. The more longer they are in PrEP, where they are at risk, the more benefit will be for them and for the community. And sometimes some people need to stop PrEP or discontinue. So for initiate PrEP, we will need an HIV test, as we said before. Nobody can be treated with PrEP if we are not sure about the HIV test, that the HIV test is negative, because we need to assess the HIV infection. If we need to identify those that had a high risk exposure in the last 72 hours to propose PrEP instead of PrEP, and then retest HIV for HIV again, and if continue being negative, just then start the PrEP. And also we need to ask to everybody before starting PrEP about the potential the presence of symptoms of acute HIV infection. The serum creatinine will be needed to calculate the creatinine clearance that need to be less than 60 milliliters per minute. And the hepatitis B surface antigen is necessary to identify those individuals that can benefit of the vaccination for hepatitis B, because it's the same mechanism of transmission. Hepatitis C antibody is necessary to identify those infected people that can be treated and to shut or to cut the transmission chains. And the same for sexually transmitted infection. The prevalence for both for hepatitis C and for STI is higher in key population, and this is the people that will be working with us. Pregnancy testing is necessary also to guide antenatal care among women started PrEP program, but it's not a contraindication. So pregnancy and breastfeeding are not contraindication for PrEP use. And also to review the vaccination history and any other preventable measures that we can share with the individual in order to benefit them of the care we are providing. But the only result that is required to document before delivering the PrEP product is the HIV test. All the other tests can be taken and evaluated in the next visit. Because they don't define the initiation of PrEP. We can discuss about creatinine, because actually we know that the clearance, the creatinine lower than 60 is a contraindication for PrEP use, but everybody knows that a clearance of 60 or lower is very rare in young people without comorbidities or without medical history of renal disease. Actually, this is so rare that the WHO is considering to take these criteria in order to simplify and expedite the treatment initiation with PrEP. So in the new proposal that will be being shared soon, and the new recommendation that was based in the information from all the PrEP program until now, those that are lower than 30 years old, if they don't have history of diabetes, hypertension, or obesity, also those are the kidney-related comorbidities, might not need to have a creatinine study during the PrEP program. Those that are between 30 and 49 years will be required to have the creatinine, but you can wait between 1 to 3 months to see the result. It doesn't need to be before the PrEP initiation. And only we will wait for the PrEP initiation, or at least no wait, sorry, we will require that need to be done in those that have some kidney-related problem or that are more than 50 years. So, so we don't need to see the creatinine before starting PrEP, and this is what is happening in the study in PrEP. For example, in Brazil, Mexico, and Peru, they take the blood and wait they start the PrEP to the participant, and then they review the creatinine. If the clearance is okay, they wait for the next visit, and if the clearance of creatinine is lower than 60, they call the participant and bring to the clinic for full evaluation with a nephrologist, because having a clearance less than 60 in a young people is a very rare event. How we assess HIV? So to be sure the participant is HIV negative, you need to document a rapid test, at least a rapid test. You can also use an ELISA, but you need to do a proper documentation of HIV testing that is negative. Even though self-testing is important it's important the country to use self-testing. Self-test cannot be used to rule out HIV, because you need to be sure that HIV is negative. So even if the individual say to you, I yesterday did an self-testing and it was negative, you need to document a new one. So these rapid tests need to be to have all the quality control that are required per local regulation. I mean, to the proper temperature, the proper recording of result, the proper validation of result, and the quality of control. In addition to the rapid test that need to be negative, as we say, we need to be sure that the individual was not exposed in the last 72 hours. It was exposed to start PrEP, and doesn't need to have symptoms of acute HIV infection. Acute infection is the symptom that develop 2 weeks after the virus enters in the body. And this happened because the viral load increased a lot, more than 10 million in some cases, and this is followed by fever, rash, myalgia, headache. As you see, this is very similar to any virosis or any mononucleosis, and so it's very difficult to discriminate if this is really an acute HIV or any other viral disease. The rashes are typical morbilliform rash that start in the trunk and go to the arms. You need to also to suspect the syphilis in any patient, young patient participant in PrEP that is having any dermatological conditions. So in this situation, you cannot start PrEP and you need to perform additional laboratories. The problem with acute HIV infection, as I said, is that even the fever is very frequent, 87%, the myalgia 60%, the rash 57% in patients with primary HIV infection. There are also these symptoms also are very frequent in general population that is not infected with HIV. So the discrimination is very difficult to do without without laboratories. So if you have some patient with any of these symptoms, you cannot start PrEP. You need to request a viral load if it's available in the country, or send the participant to some laboratory where he can have a viral load to identify if it's HIV or not, and also syphilis testing. And you need to reschedule a new HIV test in the next 4 weeks for a new evaluation, in order to be sure that the patient is negative. Obviously, this next month is a period of risk for this participant if the participant is having unprotected sex. For this reason, you need to reinforce with the participant the need to use condom and protect himself or herself until the next visit, in order to be sure you can start PrEP in the next visit. And we say 4 weeks, because as you know, the HIV has a window period where you can have an HIV negative test but the patient can be positive. So imagine you are exposed today to HIV, you will be 1 week without any symptom, without any problem, impossible to detect the infection because the viral load will be 0. But after the 1 week, the viral load start to increase, and after 2 weeks from the infection, the viral load will be so high that will be producing symptoms in your body. But at this moment, the HIV will be negative because the antibody were not developed yet. And so at this moment, you can only do a viral load test. And hopefully you need to have this result very quickly because you need to take a decision with that. Then, if you wait a couple of weeks more, some ELISAs start to be positive. The next week, the lower sensitivity tests are fully positive. So just after 1 month of the exposure, you can be sure that the HIV is negative. And for this reason, we say it's better to wait 4 weeks in order to be sure these individuals are HIV negative. We need to measure the efficacy of PrEP while the patients or the individual are receiving the PrEP. So we will measure by the capacity of the PrEP to maintain these people HIV negative. And also for this, we need to measure every 3 months the HIV and measure antibodies in order to detect, identify the infection. And also it requires to have a good adherence. So we will need to repeat, ideally, if we can, we should repeat in those individuals that started PrEP a new HIV 1 month after the initiation, because this will give you the confidence that really this individual was negative at the beginning, as I showed you in the graph. And also, in every visit, you need to continue asking about the potential signs of acute HIV infection and perform the identification of acute HIV in those individuals that are symptomatic. Also, we need to monitor the pharmacy pickup at each visit and providing counseling. Adherence doesn't need to be perfect for PrEP. This is different from treatment. For treatment, you need more than 95% adherence for the treatment to be successful. But for PrEP, there are many different studies that shows that the tenofovir accumulates in the rectal tissues and the genital tissue, and so with 7 tables, the efficacy of the PrEP protection is 99%. But with 4 to 6 pills a week, we achieve more than 90% protection. We don't need to say that to every patient, say, oh, be relaxed, you can take only 4 pills, because you can make the patient be in the 10% that can be infected or not protected, you know. But we know from these pharmacokinetical studies that if you take between 4 to 6 pills, the risk of developing HIV is very, very, very low. Remember that if your patient decided to switch to event-driven PrEP, you cannot measure adherence counting the pills, because if this individual was without having sex by 2 weeks, they will not use any pills. So you need to ask, instead of asking for pills or bottles, you will need to ask about events. How many events did you have in the last month or in the last 3 months, and how many of these events you couldn't follow the 2+1+1 cycle as indicated. This can be complex for monitoring purpose, but for clinical care and clinical management, it's not so difficult. At each visit, you need to identify adverse events. Please make sure your patients or your participants knows that at the beginning it's very common to having nausea or gastrointestinal problem. This is graph measure what's happening in a protocol, in a clinical protocol, the first PrEP trial. And you see here that people with placebo was not presenting symptoms practically, but those that started in tenofovir had 10% of the individual had nausea. And this nausea was more or less about 2 or 3 weeks, usually disappear in the first months. So feel the patient knows that they can have some gastrointestinal symptom because the Truvada at the beginning, and they can take any, gastrointestinal symptomatic medication if it needs, but the problem will resolve without any problem for the body. No specific other laboratory are necessary except creatinine every 6 months for people that are at higher risk. Remember that the kidney function, the risk of having a problem with the PrEP is very, very low. In this trial and different trial, you can see here that only 0.2% of the people had an increased grade 2 or 4 of creatinine among 5,000 patients, and only 1 of each 3,000 patients will require to be stopped the PrEP because this. And also another concern for tenofovir is the possibility of tenofovir to be implicated in osteoporosis. And you can, as you know, osteoporosis is present when tenofovir is used with ritonavir, and this increases the risk of the resorption, the bone resorption, and the tubular damage of the kidney. So it's not a problem among young people. So people less than 50 years old doesn't need to do a densitometry or a DEXA for monitoring. It's not necessary. But if the people has risk factor or have more than 50, it could be indicated to perform a DEXA to the beginning and after 1 year. It's not a recommendation of WHO, but it is some guideline in CDC guideline present as a consideration. Let's see. Then we start the PrEP, and every 3 months we need to continue looking for efficacy, doing the HIV testing, the HIV assessment, asking for symptom of acute HIV infection, doing the pregnancy test for women that can be at risk of pregnancy, doing safety assessment through question about adherence, about high risk of HIV acquisition, and offering counseling in order to reduce very high risk situation. And also the syphilis testing need to be done every 3 months. Every 6 months, we will check creatinine clearance. In addition to the syphilis, in addition to the HIV testing, we will add creatinine in this moment. And if the creatinine continue being more than 60, the individual can continue in PrEP. If the creatinine clearance is lower than 60, or is approaching or is declining fastly from 90 to 60, we need to iterate well the patient, evaluate the situation, and it can be necessary to send to a nephrologist if additional evaluation are necessary. And also every 6 months, if the country has the availability to do gonorrhea and chlamydia, it will be good to repeat those tests every 6 months. It is not repeated every 3 months because it's very uncomfortable doing the swab, an anal swab, and urethral swab, and pharyngeal swab, and also because it's very expensive. This is molecular test, so it's usually very expensive. So even in the high-income country, the tests are scheduled every 6 months. Finally, once a year, those that were tested hepatitis C negative should be retested, in particular men having sex with men and transgender women, because we know this population are at higher risk of incidental hepatitis C. So in summary, you have every 3 months to conduct HIV testing, doing pregnancy tests, reassess the need for continued PrEP use if the patient continue having in high risk situations, assess side effects, adherence, and risk behavior, provide support for adherence, prescribe 3 months of TDF FTC until the next visit, and then doing the syphilis testing. Every 6 months, we will evaluate the renal function and screen for gonorrhea and chlamydia, and once a year, we will do the hepatitis C. All this information will be collected in some specific forms that if you have the guideline or the policy guideline, you will see in the annexes the capture most of the information we are discussing. We need to have clear that PrEP is not for all individuals. It's only for those individuals who are at risk of substantial risk. And also that PrEP is not forever. We need to continue PrEP when the patient is in risk, and maybe we need to discuss with the individual that doesn't have any more risk to stop it. But while the individual is in PrEP, we need to try the individual take the PrEP correctly and with good adherence. So for those that never provided antiretroviral therapy, there are some tips for improving adherence. For those that are caring for HIV patients, everybody is very aware how to deal with these issues in order to make the adherence easier. But if you never worked with patients with chronic diseases, or in particular with HIV, you need to know that you should link the pills to any other daily routine that the patient might have. In particular, you need to ask, you brush your teeth every day in the morning? Yes, well, okay, put your pills with your brushing teeth in order to be sure to remember to do it at the same time. If the people doesn't brush the teeth, that should be good to brush, but doesn't, well, with the breakfast or with the dinner or with any activity that you usually do or perform every day. Try to take the pill more or less to the same time, but doesn't need to be exact, doesn't need to be the same minute. Usually all the medication can have a couple of hours before and after without any problem. Some people can feel useful to use pill box, and this is in particular for these young people that doesn't know very well if they will sleep at home or not. So maybe they need to use a pill box, this pill box with some backup supply in a bag or in a purse, in order to be sure that if he changed or she changed the plans and doesn't sleep at home, can have a pill for tomorrow. And also some people might need to use alarms or texts or reminders in order to remember to take the pills. If the people know what are the adverse events, will be less afraid when they present the symptom, and will understand that and will continue taking. So it's important to remember to name what the pill can do and how the pill works, and discuss this with the individual the first time you provide the pills. And also, if the patient or individual has social support, it could be good for them to discuss the concern or the other significant one, to remember them to continue taking pill or continue going to the clinic. So encourage the disclosure of PrEP to significant other, in particular if they are living with other people at home, because if the family finds the antiretroviral drugs, they might think the individual is HIV positive, and this can increase the stigma, even though if they don't disclose they found it. And finally, you need to make plans with your patient what to do in advance. What happens if I miss one dosage? I mean, it's not a big deal if you miss the dosage and less than 12 hours pass it, the individual can take the dosage, the missed dosage anyway. But if it's more than 12 hours, so it's better to wait for the next and take the pill in the established time. You need to discuss with the client when to switch to event-driven PrEP. We discussed it yesterday. that if the individual is a man having sex with men, if the individual can plan when he will have sex and when can wait 2 hours after taking the pill for having sex, they can switch to event-driven PrEP without any problem. You can discuss what to do if the individual need to travel abroad. Sometimes they will need a certificate or a piece of paper establishing that the drug need to be continued and doesn't, in order to pass the border, to show to the official that is a prescribed treatment. And then we need to discuss when the individual should stop the PrEP. The reason for discontinuation are personal choice. Some people doesn't want to take it anymore, and sometimes there are no clear reason for that. But most of the situation are because the people perceive themselves as a lower risk of HIV. So it is good to discuss with the clients what is the feeling about the risk, because even though if somebody is in a close relationship or established or decided he will not engage with other people anymore, he also is carrying the risk of the partner. So you need to be sure her partner is negative and is without additional risk. And also we need to discuss, it is very, very uncommon to stop PrEP because the toxicity, in my experience, I have one individual that couldn't tolerate enough of it, but it's very, very rare situation. And obviously, any HIV positive test will require to stop the PrEP and to implement a rapid measure to confirm the HIV and to start treatment. Because the PrEP is only 2 drugs, tenofovir, lamivudine, two low potency drug for treatment that required the additional 3rd drug in order to treat well. So if if you have any individual that is having an HIV positive test, you need to figure a formal evaluation. You need to document what happened with the adherence, if the individual was taking or not the PrEP in the last months, what were the risk behavior he had, if he had a lot of unprotected sex or not in the last months. And then you need to counsel them, explain that it is just an HIV rapid test positive, doesn't mean that it's really positive. You need to confirm. Remember, the test has 1 to 2% of false positive. So you cannot give a confirmation only with a rapid test without following the national algorithm. And for that, you need to refer the patient for a new laboratory, in particular for viral load, and eventually for treatment. Please be sure that the patient that the laboratory collect and froze sample for those patients. There are very few cases that seroconvert if they take the PrEP well. So it is very important to document these situations. And if the patient or the individual is HIV positive after starting PrEP, you want to see the viral load, you want to see the resistant test, and maybe in the future, the country can want to know if, or to perform other kind of testing in order to be sure what is the situation. In addition, there are some documents that shows, or some studies that show that the typical seroconversion that I showed you in the graphic before, that takes 1 month to seroconvert in a patient with acute HIV infection, there can be a delay in the pattern of seroconversion among individuals taking PrEP. So any HIV positive test need to be confirmed, and if the confirmed and if the results are not concordant, or if the results are confusing or ambiguous, it is good to take or to follow those participants closely and perform new testing every month until you are very sure the individual is HIV negative. And because, or for why? Why? Because if the individual, as we said yesterday, if the individual is HIV positive and continue taking only PrEP, you can develop resistance. So this is the graphic of the resistance until now with PrEP among 8,000 people in different clinical trials that were taking PrEP. There were 248 infections from 8,000, but only 10 resistant cases. In most of the cases in partner PrEP and FemPrEP, this was due to very, very bad adherence. And but if during acute HIV infection, if you continue giving Truvada, you increase the risk of the people of accumulating resistance, as we said yesterday. This can be concerning, but you need to take into account that these only 10 cases among 8,000 is only 0.1% of the cases that are treated that develop resistance. And thank you to this, you can avoid more than 150 cases. So it's important to think in the phenomenon, but it's not something that need to worry too much if we do the thing well. I mean, if we stop the PrEP when the HIV is positive and if we submit this individual for treatment. How to avoid resistance? Okay, preferable in any patient that start PrEP, repeat the HIV the first month and then schedule every 3 months visit. But having 1 month HIV after the PrEP initiation make you sure that you didn't miss a window period or the window during the acute HIV infection. Never reinitiate PrEP without an HIV testing. If somebody stopped PrEP for more than 1 week continuously, you should want to repeat this HIV testing before restarting the PrEP. Remember to ask about high-risk situation before starting PrEP, and those that are in very high risk put on PEP and then pass to PrEP. And also pay attention to the presence of acute HIV infection symptoms in every visit. Ask about fever, myalgias, and rash. If any sample is positive, repeat it. If it continues being positive, cancel, discuss risk, adherence, report to the central laboratory, take sample for viral load, for CD4, take sample for genotype. If you cannot do the phenotype at that moment, froze the sample for future studies and refer for treatment. Interactions are not really a problem with PrEP. I mean, as you see here in the graph, the interaction are only those that are red. There's only one drug that cannot be taken with PrEP, that is Adefovir, that is a drug for hepatitis B. It's very rare, and I am sure nobody's using it in Belize. So don't worry about interaction. Doesn't decrease or increase the hormonal level. The transgender women can take the PrEP with hormonal drugs. The women that require PrEP can take it while are taking other drugs for contraception. People with diabetes or hypertension can take PrEP without any problem. But you need to reflect.
Dr. I believe someone's mic is on.
But you need to know that the non-steroidal anti-inflammatories doesn't interact with PrEP, but the non-steroidal anti-inflammatory reduce the flow of the kidneys and can produce kidney diseases. So you need to avoid those drugs in a high frequency or high doses. So if people need to take diclofenac or ibuprofen in high doses, they need to hydrate well, take a lot of water, and try to reduce the use of these over-the-counter drugs. Finally, please and take note of these resources. You can do the pre-exposure prophylaxis course. It's an e-learning course of 4 weeks. You can take it in the PAHO Campus Virtual, and this is the address, or you can put in Google Campus Virtual PAHO PrEP, and you will have it. And also you can download in your phone the PrEP toolkit from the WHO and the PAHO, and you can see here all the information that we present. Thank you very much for your attention, and I am open for questions.
Thank you so much, Dr. Omar. Kindly excuse the background noises right now. I'm now going to call on Dr. Hortensia to provide us with a presentation on STI, hepatitis viral management in the context of PrEP. Again, apologies for the background noises.
You can see my presentation.
Yes, we can.
Okay. Good morning, everyone. Thank you very much for being here and for the invitation for us. One of the issues intrinsically related to the implementation of PrEP is the approach of the STIs. As we mentioned yesterday, PrEP is an intervention for people at substantial risk of acquiring HIV, which also implies that these people are also at risk of acquiring an STIs. Several questions that may arise in the implementation of PrEP and its relationship to the STIs other than HIV and other diseases such as hepatitis will be addressed in this session. We will attempt to answer the following questions. What is the relationship between STIs and PrEP? What is the difference between the syndromic approach and the etiologic approach to STIs? What are the manifestation, diagnostic consideration, and management of STIs of public health importance, and how to integrate the hepatitis approach in the PrEP service? This is I try to make shortly, but I try to be more shortly in related to the time we have, but I will try to go slowly, no? What is the relationship between STIs and PrEP? It is important to analyze this relationship from the point of view of the efficiency and the effectiveness of PrEP service. We cannot forget that this is an opportunity to assess a group of people who are at risk of acquiring an STI, including HIV, and a balance needs to be struck between providing essential service versus a more comprehensive package that includes not only the provision of primary HIV and STI testing service. We can then consider including with the service provision the assessment of other essential tests, such as hepatitis, hepatitis B, hepatitis C, the assessment and need for sexual and reproductive health service, family planning, elements of mental health preventions, element of comprehensive sexual health. In the chat, someone that said the anal health is important. Yes, of course, all the anal health and all the review of the genital part is also important. All the elements, the preventions, and the comprehensive sexual health that enable people to express their sexuality safely without fear of becoming ill. Therefore, the integration of a screening service for STIs and other diseases and an holistic person-centered approach can allow us to be more efficient and have an impact on person overall health status. A recurring question in this relationship between PrEP and STIs is whether there is an effect on the sexual behavior of people receiving PrEP. Studies show that there is not evidence in favor of risk compensation in the sexual practice of PrEP users. But what does risk compensation mean? Risk compensation is a theory in which anyone in a risky environment adapts his or her behavior to changes in the level of risk or she perceives. If the person detects an increasing risk, will act more cautiously, and if on the contrary detects an decreasing risk, the person will behave in a more carefree manner. In this way, it compensates for changes in the level of risk, returning to the level of risk it considers acceptable, which is usually variable for each individual. In this slide, we can see the data from studies such as Afoner et al. At PROUD. The PROUD is a very big study, include PrEP versus non-PrEP, reveal no evidence of risk compensation in the sexual practice of PrEP users. Furthermore, there are no difference in STI rate in PrEP users, not increase in sexual partner, and no significant change in condom use practice. It is always important to mention that despite the study's result, counseling on risk reduction, management, and periodic screening for STI should be provided at each visit before and during PrEP use. We name combination prevention strategy. It's important we have this like an opportunity to give educations to the young people or the old people and the use of the condoms for anal sex, and also made routine testing and comprehensive treatment of high prevalence STIs since among MCM, including the STI for the public health importance is syphilis, chlamydia, and gonorrhea. Even with the existing evidence, people still question whether or not incurring PrEP increase the incidence of the STIs. How can we evaluate this issue? Synthesis of data from 8 studies shows the PrEP use was significantly associated with increased odds of any rectal STI diagnosis. Also, PrEP use was significantly associated with increased odds of rectal chlamydia diagnosis. This means that the evidence shows that diagnosis is increasing in a group of people who are screened, and therefore highlighting that it's an opportunity to offer treatment and cure, because these three STIs, chlamydia, gonorrhea, and syphilis, can be cured with adequate treatment. It also offers an opportunity to assess the contacts of these people. Oral PrEP is an opportunity for prevention and control of STI. It is critical to recognize that PrEP services are an entry point to STI and sexual reproductive health that previously and otherwise at-risk individuals would never have access. It is therefore a time for educational and counseling intervention to achieve full sexual health. Think of the moment when a young man, MCMs, come to a clinic asking about this shiny new pill that protects against HIV. Then that's the moment he can learn about and receive prevention service for other aspects of his sexual and general health, including routine screening and comprehensive treatment for high prevalence STI is very important for PrEP service. We have 2 different approaches for addressing the STIs according to the diagnosis. When we're discussing the difference between etiological and clinical diagnosis, it's considered that clinical diagnosis is performed using clinical expertise to identify symptoms of a specific STI. It is often used when laboratory services are not available or there is concern that follow-up will be lost. Etiologic diagnosis is made using laboratory tests to identify the causative agents. Treatment is initiated when results are available. Although not always available, point-of-care diagnosis is the ideal approach so as not to delay treatment. It's important if we only have a clinical diagnosis, where we can see in the other slide the syndromic approach. And is this the only approach we can do for the people? Well, is this better than nothing? But it's necessarily we need to work from the etiological diagnosis because this gives us evidence to the agent, the causative agent, and also reveal more about the curative patterns in the people of in our care. Treatment should not be delayed while waiting for an etiological agent. For this reason, if we don't have etiological diagnosis, we need to work with the syndromic case approach. This is problem-oriented and aimed at treating the patient at the first visit. While a clinical or etiological diagnosis tries to identify just one causative agent, syndromic diagnosis leads to immediate treatment for all the most important causative agents. It is important because mixed infections occur frequently, no? Several different organisms that cause STI gives rise not only a limited number of syndromes. For example, a patient complained of a discharge from the penis. Upon examination, it is noticed a discharge from the urethra. The sign and symptoms together suggest urethral discharge syndrome. Urethral discharge syndrome is commonly caused by gonorrhea and or chlamydial infection. Not only can this cause serious complications, but also they can facilitate the transmission and acquisition of HIV. It is therefore essential that we treat the patient for both. In this case, in the syndromic approach, in the urethral discharge, we need to give combined treatment for gonorrhea and chlamydia. Okay, moving to the diagnosis and characteristics of the three principal diseases, STIs, of the public health concern. The syphilis is a systemic disease caused by Treponema pallidum. The disease has been divided into stages based on clinical finding, guided treatment, and follow-up. I want to concentrate in this presentation especially on the clinical manifestations and also some kind information of the algorithm. And if you have questions, please put it in the chat and we can answer later. Or if had another issue about the algorithm or the treatment, please go ahead in the chat and we can read later. Also, we need to review public health considerations aimed at preventing ongoing transmission and controlling the burden of disease in the community. These public health considerations include the identification of contacts, optimization of existing disease surveillance systems, and also interview of person diagnosis with infection syphilis to identify emergency risk factor associated with the syphilis acquisition in the community. We can see in this slide the natural history of syphilis and overview of signs and symptoms. Syphilis as a disease is not easy to diagnose, especially because the incubation period can be got tan short as like 10 days or as long as 90 days. And the symptom or manifestation of the disease can occur in the very short time in the primary infection or advance to the secondary manifestations of more than 1 year in the latent syphilis, or even though when manifestation of the tertiary syphilis in the cardiovascular gomatose and also in the neurosyphilis, and the manifestation can be present until 10 or 30 years after infection, like a tabes dorsalis or late neurological manifestation and general paresis. The early neurological and clinical manifestations like cranial nerve dysfunction, meningitis, stroke, and affectation of the hearing or ophthalmic abnormalities usually occur within the first week, the first few months of year of the infection. And the late neurological manifestation occur even though 30 years after infection. For this reason, we can receive the person asymptomatic or symptomatic, and we need to make a very good clinical history, not only in the past month, or the 2 past months, of the 90 days before at this time. If we analyze a patient with symptoms neurological, without any concern or without any cause, we need to investigate more behind, because the incubation period is very variable in the different case. The primary syphilis is very easy to identify in pictures, but it's not so easy to identify in the real life, because following exposure, a localized infection occurs at the site of initial inoculation, but this classical, the primary syphilis lesion can begin as a macule, progressing to a papule, which then erode to becomes the classic painless ulceration named syphilis chancre. You can see the picture is a clean ulcerative lesions, normally painless, normally is just one. But in the immunodepressive patient, like HIV patient and other immunodepression situations, also can be present like multiple lesions, and also normally is painless, but also can be present like multiple painful lesions, similar to the herpes or similar to the chancroide. We need to review and make the laboratory test for make the differential diagnosis. So the most of the time, the person cannot perceive this type of lesion when it's painless. In the contrast to the localized finding in the primary syphilis, secondary syphilis present as disseminated systemic form of infections. Dermatological manifestation of secondary syphilis include a variety of rashes, classically involve the palm and soles, wart-like growth, mucous patches, and alopecia. Skin findings are often accompanied by generalized non-tender lymphadenopathy and non-specific symptoms such as fever, headache, muscle ache, and fatigue. You know, if you see this rash, the first pictures, and the person comes to the consultation with headache, fever, and this rash, you need to make a very good clinical history to suspicious secondary syphilis. It's more frequently when you can see the rash in the palm and the soles. This is very classic from the secondary syphilis. Tertiary syphilis can present with cardiac involvement, gomatose lesion, tabes dorsalis, and general paresis. We need to know, for the diagnostic consideration of syphilis, for the presumptive diagnosis require use of 2 tests. First, non-treponemal tests can be RPR or VDRL, and treponemal tests can be TPPA or rapid test. we need to know the antibody titers in the non-treponemal test might correlate with the disease activity and are used for monitoring treatment response. Serum should be diluted to identify the highest titer, and results should be reported quantitatively. A fourfold change in titer equivalent to a change of 2 dilution. For example, if we have 116 to 14 or from 1.8 to 132, is considered for diagnostic, but require confirmation with treponemal test. The treponemal test might persist positive for life in the 75% of the people. And the treponemal test, if positive, when it confirmed with the non-treponemal test. We have 2 algorithms to syphilis diagnosis, the traditional algorithm and the reverse algorithm. The traditional algorithm is when we use the RPR, one non-treponemal testing, RPR or VDRL, if this non-reactive or reactive. If this non-reactive and we don't have serological evidence of syphilis, it's important does not rule out incubated or early primary infection. If the non-treponemal test is reactive, we need to do the treponemal testing are available in the country on the algorithm. And if this is non-reactive, it is considered a false positive non-treponemal result. And if this is reactive, this is a syphilis infection, current, untreated, or previously treated infection. For this is important. Correlate the result of the algorithm with the clinical history. In the case of this traditional algorithm, we need to recommend in patients with no history of syphilis treatment and isolate reactive RPR could represent partial early seroconversion if the patient report a recent exposure to a syphilis case, present with a skin lesion suspicious for primary syphilis, has a high non-treponemal test titer, example, more than 1.8, or an increased risk for syphilis, we need to repeat testing in 2-4 weeks, might reveal further seroconversion, including reactive treponemal specific testing. If a patient is a high risk for syphilis and there is a significant risk of loss to follow-up, presumptive treatment could also be considered. It's important, it's better to give treatment if we have suspicious and in consideration to the loss of the follow-up, because the syphilis it can be cured. In the reverse sequence algorithm, in this case, with the increased availability of different treponemal tests and automatic treponemal specific immunoassays, the reverse sequencing algorithm is increased the use. In this case, we can use AEA or CIA or other treponema pallido immunoassays like a rapid test. If this is non-reactive, is mean no serologic evidence of syphilis. We need to remember this is a treponemal test. If this is reactive, we need to do a RPR or VDRL, whatever is available in the country. And this is non-reactive. We need to repeat the treponemal test with another test different of the first. For example, we can use TPPA. And this TPPA is non-reactive. This is a false positive AEA, CIA. This is a false positive immunoassays. And this is reactive. This is a syphilis infection. In the context is the rapid test is reactive and the non-treponemal pallid in the non-treponemal test is reactive, we are in front of the syphilis infection, and we need to know is this is current, untreated, or is someone is previously treated. Person with a positive treponemal screening test should have a standard quantitative non-treponemal test with titer performed by the laboratory to guide patient management decision. If the treponemal test is negative, the laboratory should perform a different treponemal test that we were talking before. It is important if the second treponemal test is positive and the individual have a history of previous treatment will not require additional treatment unless sexual history indicate re-exposure. In this case, repeat non-treponemal testing is recommended 2 or 4 weeks after a confirmed history and physical examination to assess for early infection. Person with no history of treatment for syphilis should be offered treatment unless clinical history or physical examination findings indicate recent infection. Previously untreated person should be treated for syphilis and on non-duration or late latent syphilis. Remember in the case of the pregnant woman, I know this is not necessarily the case because it's not the first or the primary target for the initiate PrEP, but it can be possible if we have a rapid test positive in the pregnant woman. We give treatment and we evaluate before, because we need to assure the treatment for the baby and for the work of the syphilis, elimination syphilis, congenital syphilis. Syphilis treatment consideration, the benzathine penicillin is the treatment recommended for the primary, secondary, early latent syphilis. 2.4 million units intramuscular for 1 dose, except in the case of the late latent syphilis, we need to give 3 doses, and also in the HIV patient, we need to give 3 doses, but we are talking now in the context of PrEP. Suppose this patient is HIV negative, if is primary, secondary, or early latent, we need only 1 dose of benzathine penicillin. If the penicillin allergy, we can give doxycycline, 100 milligram orally 2 times a day for 14 days and 28 days in case of latent syphilis. Well, in the case of the pregnancy woman, we need is the assess if the pregnant woman is allergic to penicillin, and this is a whole different process. We need to make we need to make the test of the penicillin allergy, and if it really is allergy, we need to desensitize it because it's the only treatment for the pregnant woman. For the follow-up, non-treponemal test antibodies correlate with disease activities. A 4-fold change in titer equivalent to a change of 2 dilutions, for example, 1/16 to 1/4, or from 1/8 to 1/32. These changes revealed is correlated with the treatment. Most patients who have reactive treponemal tests will have reactive tests for the remainder of their life, regardless of the treatment for this or disease activities. 15 or 25% of the patients treated during the primary stage revert to being serological non-reactive after 2 or 3 years. Another part important in the management of the syphilis is the partner management. In this case, the person exposed sexually to a person who has primary, secondary, or early latent syphilis should be evaluated clinically and serological and treated according to the following recommendations. Person who has sexual contact with a person diagnosed with primary, secondary, or early latent syphilis within 90 days preceding the diagnosis should be treated presumptively for early syphilis, even if serological test results are negative. Person who had sexual contact with a person diagnosed with primary, secondary, or early latent syphilis more than 90 days before the diagnosis should be treated presumptively for early syphilis if serologic test results are not immediately available and the opportunity for follow-up is uncertain. If serological tests are negative, no treatment is needed. If serologic tests are positive, treatment should be based on clinical and serological evaluation and state of the syphilis. All partners exposed to an index case with primary, secondary, early latent, less than 90 days should be informed about the risk and offering treatment when one dose of benzathine penicillin. Well, we are moving forward to another type of STI. The other STI with a public health consideration is the chlamydial and gonococcal infections. In this case, the asymptomatic infection is common among both men and women. To detect chlamydial infection, healthcare providers frequently rely on screening tests. Although evidence is insufficient to recommend routine screening for chlamydia trachomatis among sexual active young men because of certain factors like feasibility, efficacy, and cost effectiveness, screening of sexual active young men should be considered in clinical setting with a high prevalence of chlamydia, for example, adolescent clinic, correctional facilities, or STI special clinics, or for population with a high burden of infection. For example, this case, this is a PrEP user. No? The diagnostic consideration for the chlamydial and gonococcal infections are very important. The specific microbiologic diagnosis of Neisseria gonorrhea infection should be performed for all persons at risk for a suspect of having gonorrhea. A specific diagnosis can potentially reduce complication, reinfection, and transmission. Culture, NAT, and point-of-care NAT, such as GeneXpert, are available for detecting genitourinary infection with Neisseria gonorrhea. We can see the sensitivity for diagnosis from chlamydia with expert is more than 90% in comparison with the rapid antigen test is also sensitivity for 50%. In the case of gonococcus, the sensitive is more than 90%, is very close to the culture. NAT sensitivity for detecting Neisseria gonorrhea from urogenital and non-genital anatomic site is superior to culture, but varies by NAT types. With the expert, you can see is almost similar, and the difference is is more easy with GeneXpert. It is a point of care, and the result can be done in 2 hours. For women, chlamydia trachomatis urogenital infection can be diagnosed by vaginal or cervical swab or first void urine. Chlamydia trachomatis urethral infection can be diagnosed in men by testing first void urine or a urethral swab. NAT are the most sensitive tests for this specimen and are the recommended tests for detecting chlamydia trachomatis infection. The prevalence of rectal infection from gonorrhea is to rise to the 24% and chlamydia 2.1 to 23%, and the prevalence of pharyngeal infection also is different in gonorrhea, and chlamydia is superior for gonorrhea. The happen is the most of the testing chlamydia and gonorrhea testing both on the same cartridge, and we need to know the prevalence of the gonorrheal infection in the pharyngeal is more greater than chlamydia, and the most of the people are asymptomatic. Annual screening for rectal chlamydia trachomatis infection should be performed among men who report sexual activity on the rectal site. This is a recommendation to do also in the people on PrEP. 70% of the chlamydia and Neisseria infection might be missed only testing urine. In this table and in this slide, we can see different clinical patterns related to discharge syndrome, especially urethral discharge, vaginal discharge, and proctitis. The most common causes are gonorrhea, chlamydia. In the case of the proctitis, syphilis can be involved, but in the vaginal discharge, we need to differentiate in the vaginitis and cervicitis. In the case of vaginitis, trichomoniasis is also included in the different diagnoses, but we can see the most etiological causative agents for the different discharge syndromes are gonorrhea and chlamydia. In the case of discharge syndrome, urethritis in the man is characterized by urethral inflammation, can result from infectious or non-infectious conditions. The symptoms include, if present, include dysuria, urethral pruritus, and mucopurulent or purulent discharge. We saw in the slide before the most causative agent more frequently are Neisseria and chlamydia, and the diagnosis can be done for using NAT are preferred for the detection of Neisseria and chlamydia, and urine is the preferred specimen in males. In the case of the woman, it's a little different because the syndrome of discharge can be related to vaginitis and cervicitis, but frequently is asymptomatic. Unfortunately, it's not easy to distinguish between cervicitis and vaginitis, especially when it is impossible to do an internal examination. Cervicitis is more likely in areas where the prevalence of gonorrhea and chlamydia is high. The higher the prevalence, the stronger the justification for treatment. It's usual for women to have some vaginal discharge, and women may notice it more during certain phase of the menstrual cycle, during and after sexual activity, and during pregnancy and lactation. Usually women complain of vaginal discharge when they think it is unusual for them or cause itching or discomfort. In general, they will not seek medication for a secretion they consider normal. Women develop the symptom of vaginal discharge if they have either vaginitis or cervicitis. It is essential to distinguish between these conditions because one of them, cervicitis, leads to severe complications, so the patient's sexual partner must also be treated to avoid reinfections. Two major diagnostic signs characterize cervicitis. The first is the purulent or mucopurulent endocervical exudate, and the second is the sustained endocervical bleeding easily induced by gentle passage of a cotton swab through the cervical os. Either or both signs might be present. For the consideration of the treatment, several factors should be affect the decision to provide presumptive therapy for cervicitis. Presumptive treatment with antimicrobial for chlamydia trachomatis and Neisseria gonorrhea should be provided to women at increased risk. Sample those aged less than 25 years and those with a new sex partner, a sex partner with concurrent partner, or a sex partner who has a sexually transmitted infection. Mailing in a follow-up cannot be warranted or if testing with NAT is not possible. Trichomoniasis and bacterial vaginosis should also be treated when detected. It's important in this case that the recommended treatment regimen is need to be for chlamydia and for Neisseria. We need to give ceftriaxone, 500 milligram intramuscular, doxycycline, 100 milligram twice, 7 days, and if necessary, 21 days in proctitis. A meta-analysis and Cochrane systematic review evaluate data from different randomized clinical trials of azithromycin versus doxycycline for treating chlamydial infection and determined that microbiological treatment failure among men was higher for azithromycin than for doxycycline. For this reason, the recommendation is ceftriaxone plus doxycycline. It's important also to minimize the reinfection risk. Patients should be instructed to abstain from sexual intercourse until all their sex partners have been treated. Persons who receive a diagnosis of chlamydia should be tested for HIV, gonorrhea, and syphilis. MCM who are HIV negative with a rectal chlamydia diagnosis should be offered HIV PrEP. The strategy of the partner notification is a public health intervention for the control of STIs. It helps reduce further spread of STIs. Spouses, sexual partners are notified and invited for testing, counseling, and treatment if necessary. It helps to ensure that affected individuals get treatment, especially those critical for infection that are often asymptomatic or latent. Can change behavior to reduce the spread of the infection. This is the source is National Collaborating Center for Infectious Diseases, because this is a strategy in the WHO is recommended the partner notification from HIV, but not in the formal way for the STIs, but we need to consider this is a public health intervention for the control of STIs, and if it can be done, it will be good. Final, I know this is a long presentation, but I try to highlight the first and principal issues of the different diseases. And the last disease is hepatitis, and we need to how to prevent and manage hepatitis into the PrEP cohort or the PrEP service. If possible, vaccinate for hepatitis A to MCMs. Not all the programs, national program include hepatitis A. Is not recommendation. A strong recommendation or it's not just for PrEP program. Maybe this is for children, but if we have people into the key population, if not suffer hepatitis A and is possibly receive the vaccinated, is recommended. The screen for antigenous supervision of hepatitis B, it is important and recommended for PrEP user. It is positive, refer to hepatology and counsel not to stop PrEP. And if the most important, if the antigenous is negative, this person is candidate to vaccinate. And if only if available can measure anti-hepatitis B score, but this is not obligation. But the vaccination is highly recommended. The screen for hepatitis C annually is important for PrEP user and drug users. Inform about the potential risk among MCM. A screen in case of liver function test alterations. Continue with hepatitis. Hepatitis B vaccination is recommended for all unvaccinated and infected persons who are sexually active with more than one partner or are being evaluated or treated for an STIs. Hepatitis A and hepatitis B vaccine are recommended for MCM persons who inject drugs, persons with chronic liver disease, and persons with HIV or hepatitis C infections. Unfortunately, at the moment, we don't have a vaccine for hepatitis C. You can see the symptoms and the incubation period are different, but the symptoms are very, very general. It's not a very clear symptoms to can give us a light for think on hepatitis. When we can think on hepatitis, maybe the patient have a very established disease. And the time for intervention is the prevention. Remember the hepatitis B and hepatitis C, The method of transmissions as parenteral and also in the hepatitis B is the sexual contact. For this reason is included in the risk, substantial risk of acquisition of HIV practice. Hepatitis treatment. In the case of hepatitis A, no treatment available until now, but is available. A vaccine can be used in the children, and the different population don't suffer the disease yet. Hepatitis B is not curative treatment, but tenofovir that used for PrEP will suppress virus and avoid progression. In the case of hepatitis C, until I see maybe 5-6 more years ago, these people received almost a fatal notice when they received the diagnosis of hepatitis C, because the treatment was inaccessible, it's so expensive, but now exists a curative treatment, several options, including sofosbuvir, and this treatment is available to the strategic fund for the purchase for the countries, affordable price, and can be used for the patient, and the patient receive a curative treatment. For the conclusion on this presentation, I want to highlight this important to move toward the integration of testing service and a person-centered approach, which is achievable through PrEP service. Syndromic diagnosis is useful, especially for first visit treatment case or if there is a risk of loss to follow-up. Moving toward etiological treatment will allow to know the etiological patterns according to the presenting syndromes. Etiological treatment as a point of care is the treatment of choice and is accessible in terms of cost effectiveness, aiming to achieve cure and rational use of antimicrobials. The integration of hepatitis care is achievable through PrEP service. The most important, we can do it. We can do it together if we work in the integration of this diagnosis, testing of these diseases, and also sensitization and training for the healthcare worker and the participation with the civil society. We can do it. Thank you.
Thank you so much, Dr. Hortensia. At this point, I think we should perhaps open the floor for any questions. I know we've had two back-to-back presentations thus far, and there are quite a number of questions in the chat. Questions along with statements. So if anyone would like to raise any additional questions or reiterate the question that you put in the chat box, please go ahead and do so at this point.
Okay, let's see. Caleb is asking about any diversity sample in this study, the factor in poverty and inconsistent use of PrEP. So there is a link between NCD and keeping the PrEP region. There are a lot of research along social determinants of health and inequity and PrEP access and PrEP outcomes. The most important study is in the region is the InPrEP study that is being done in Mexico, Brazil, and Peru, and is enrolled more than 7,000 individuals, young individuals, and they could identify as a risk factor for non-retention, for non-adherence, and for failure of PrEP, young people in particular in poverty areas from Peru. So each, and this was worse than the poor people in Mexico and Brazil. So there are a lot of different contextual factors in addition to poverty that includes also the substance drug abuse, the lack of housing or stable housing, the stigma in the health center, and the access in the health center. And for this reason, it's good to be aware of this inequity, and while the program is progressing, the recommendation of PAHO to the different Ministry of Health in the region is to monitor who is accessing PrEP and implement additional measures to ensure the access is equitable, in particular for those young and poor individuals and for transgender women, in order to benefit more people from the program and go to what they are the really affected. Kevin is asking about sexual health. I think Hortensia addressed that. I think it's an important, but doesn't need to be a barrier. I mean, it doesn't need to be, it is not necessary to have a proctologist to start a PrEP clinic, but if you have an proctology or even a trainee doctor that can do an anal examination is good. So this is more something that need to be worked at the site level. Kevin said that Ministry of Health created a blueprint program. They think dealing with heterosexual client. How does the blueprint translate in the discussion? So I think Kevin, no, Caleb. Will debatable PrEP deals with preventing and the long term of use now become post-treatment to reduce virus to then detectable? I don't see the question here. But as I said before, yes, there are many studies in adherence of PrEP. We don't want it to overburden you with a lot of slides, but I can share my email and you can, and I can send you any on Hortensia can send any published article that that you can check this information. There are many studies in adherence.
And
I think we have in the program also the intention to have in Barbados presenting the experience. This was not possible, but we will try to ensure to share the experience in the future through some publications, some information. And then Natalia say, could it be that the increase in STI prevalence with PrEP use is due to increased high-risk behavior because the person believes they are not on treatment to prevent, don't need to worry about risk behavior and practices? And I will let Hortensia to discuss this, what we call
no, because I explained, no, it's not compensation risk in the PrEP user. Say in the other way, if the person use condom, use the PrEP, continue use condom, no? Is the usual. If the person don't use condom, maybe it's not continue not use condom. Yeah? But the more diagnosis of the STIs is more than opportunity, because we have a pool of people that are screening. We are screening, we are diagnosis. If we are not screening, we don't have diagnosis. And if we have 5,000 people and 5,000 people are screening, we have diagnosis of the STIs. In other contexts, STIs is how to say it, abandonadas. Omar, how come? It's almost a neglected disease, STI, because nobody testing, and the key population not only maybe concerned in the pregnancy, but for the general population of the key population, the testing of the syphilis and another STIs are almost neglected. And this is an opportunity, and this increase of the case is maybe related for the increase of testing. I don't know if Omar can add it to more, but
no, I think it's okay. Any other question or comments?
In the presentation, I want to have I want to make a question for the people in the audience, but because if the presentation was too long, I don't stop. But I want to know, in the algorithm they use from the diagnosis of syphilis, what type of algorithm that use now? If someone can answer and participate, and if exists any doubt about non-treponemal test and treponemal test. No? Everybody is asleep for the presentation.
Perhaps you could repeat the question once more, Dr. Hortensia, if persons didn't hear.
Okay. If somebody can explain to us what is the algorithm for the diagnosis from the syphilis in this moment at the country?
So is it the traditional or the reverse?
The traditional. Okay.
Oh,
And
no, I'm not answering Dr. Hortensia. I'm just prompting to say, is it the traditional or the reverse?
Okay.
Dr.
Yeah,
Shande thought you were saving us and you were answering on behalf of the team, no? So, but anyway, maybe our colleagues from Ministry of Health can chime in.
We have
because
response via comments, two responses.
yeah, in the chat they said we use the RPR for diagnosis, but how I explained in the presentation, for presumptive diagnosis we need to use both non-treponemal test and treponemal test. We have the traditional algorithm and we have the reverse algorithm. Which algorithm are you using? Are you using? Or are using both algorithms in different situations?
I think if you're starting with an RPR, it's probably the traditional one.
But then when they use the RPR, where treponemal test use it? Rapid test or what TPPA? What type of treponemal test are using? Okay, because RPR and VDRL is the same principles. Both are non-treponemal tests. Both can be diluted and obtain titers because it's not only get the positive, reactive or non-reactive, positive or not positive, because we need to analyze the titer of dilution of the RPR and also the VDRL. It's the same. Just the RPR is more easy to do it in the context of the community setting. It's not a point of care, but at least can be done in a small laboratory. When we perform the non-treponemal test, we need to perform the other type of test. It's a treponemal test. We don't need to go to the hospital. We can do this algorithm in the same day. Okay, maybe this is something with the presentation and the evidence, maybe it can review and maybe for the procedure, because especially it's not, this is the population, but it's in the pregnancy woman, we need to act fast, no? And also in a key population, we have a high risk of loss of follow-up. We need to take actions with this available treponemal and not treponemal tests for doing appropriate diagnosis in the same day is possible, no?
Hortensia, I was going to share some information that I know based on the EMTCT and what they're using, but I see Miss Hunter, I think it's Amy Hunter, she has her hand up, so she could go ahead.
Good morning, Doctor. I think what you're not taking into account is here we do the RPRs at the public hospitals, the regional hospitals. Confirmatory testing is then done at central lab. So unless we have someone from central lab here telling us what exact testing they're using, I believe is the ELISA that they use, but we can't say if the algorithm is completed or not because we don't do the full algorithm in our hospitals or our clinics.
Okay.
So that's where
this is good. And this is important because diagnosis syphilis is not easy. You can solve the natural history of the syphilis. You need to review more. I can share with the a monography with the New York and also the guidelines. Unfortunately, until now, we don't have clinical guidelines for the key population, but this is a working in progress. But I can share with the presentation also a few articles, a few information they can help us to understand better how can we done the diagnosis of the syphilis. Okay, thank you very much, because this is very important because the syphilis on the rise on the key populations. We need to address also the syphilis that when we address the HIV. Thank you very much.
Any additional questions before we move forward? If there are none, I'm going to call on Dr. Shante to provide us with a presentation on new modalities for HIV prevention and the future of PrEP.
Oh, my apologies. You can see this now?
Yes, we can.
Okay. Sorry, I don't know what happened with the technology a few minutes ago. All right, so thank you very much. I am going to talk through very quickly. I know we're running a little bit behind time, but talk through very quickly what is the future of PrEP. So what is really happening in addition to everything that we discussed yesterday and today, and the use of Truvada for oral daily PrEP as well as PrEP on demand, what are some of the newer modalities? And so really the objective is to share an update on some of the ongoing clinical trials and new areas of development for PrEP. So some of what I'll touch on includes the intravaginal ring, implants, injectable, and antibodies. So, but before I get to that, I just wanted to add a little bit in terms of the discussion around daily Truvada for PrEP. So we've heard about that yesterday and today, but you may have also heard of Descovy, which is, so we know Truvada is tenofovir and emcitabine. Descovy is TAF plus emtricitabine. And so 7 years after Truvada was actually approved for PrEP, In 2019, the US Food and Drug also approved Descovy, which is TAF plus emtricitabine, for people who are HIV negative and at risk for sexually acquired HIV through anal sex. At that time, there was a lack of clinical efficacy data that really prevented the US FDA from recommending Descovy as PrEP for people who may be exposed to HIV vaginally. And so what the study did really, it compared the safety and efficacy of the two options. So Descovy versus Truvada to HIV negative men who have sex with men and transgender women. This was quite a large study. 5,387 participants were registered in the US, Canada, and across Europe. The majority of participants in the study were MSMs and transgender. At the end, a total of 22 participants seroconverted during the course of the study. 7 were in the Descovy group or the emtricitabine plus TAF, and 15 were in the emtricitabine TDF or the Truvada group. And so while the numbers are different, 7 in the TAF group, 15 in the tenofovir group, statistical analyses showed really that the Descovy was non-inferior to Truvada, and that is what really led to the approval by the US FDA of Descovy or emtricitabine and TAF as an additional option for PrEP. So we know that, so the study, the Discover study did conclude that emtricitabine and TAF is non-inferior to Truvada for preventing HIV infection in cis MSM, transgender women at high risk for HIV acquisition. So both regimens were actually really well tolerated with low rates of discontinuation as a result of adverse events. And Descovy or FTC TAF was associated with significantly more favorable renal and bone safety. And we know that for sure because Descovy contains TAF, which is really, as we know, a prodrug of tenofovir that concentrates in the higher intracellular levels where the drug is really needed and has the bulk of its effect, but consequently to that, there is lower levels of the drug in the bloodstream. And this is of course what contributes to Descovy having significantly more favorable renal and bone safety outcomes. What was interesting is that the impact on lipids differed between the Descovy and the Truvada arm with greater decrease in lipoproteins, cholesterol, triglycerides when compared to the TAF arm. There was some weight gain and body mass increases, which was significantly higher in the Descovy or the TAF arm. And so in 2019, Descovy was approved by the US FDA as an additional option for daily oral PrEP. Just to know, so this is an additional option for PrEP, but Descovy in the US cost about $2,000 per month per patient. And so it's really very expensive. And I think that's why we all know why we're having a discussion on Truvada for PrEP. So I'm gonna move on to injectable. And I know this has been really on our radar in the recent few months. So long-acting antiviral drug that's injected into the body. Of course, we hear about adherence and pill fatigue and so on. And this is what an injectable offers: less frequent dosing. The need for oral dosing is bypassed. And because of that, the bioavailability of the antiretroviral drug is about 100%. We've seen that they have less adverse events, less drug-drug interactions, and because of the nature itself of an injectable once every 2 months, there's an avoidance of HIV-related stigma. And so there were two main studies that led to the approval of the long-acting injectable, the HPT and OA3, that was done among MSM and transgender population, and the HPT and OA4, OA4 that was done among cisgender women in sub-Saharan Africa. So very quickly on HPT and OA3, this was focused on MSM and transgender. The study was randomized, so there were two arms of the study. The first step of the study lasted for 4 weeks. And participants in step 1, if you follow the graph, in step 1, participants for 4 weeks were given oral cabotegravir. And in the second arm were given Truvada, daily Truvada plus placebo. Once the 4th week was over, then the study went into the second arm where participants were given long-acting cabotegravir injectable plus a placebo, oral placebo. And in the Truvada arm, participants were given Truvada, oral Truvada daily plus a placebo injection. What the study did show in terms of the results is that there were a total of 52 infections that occurred. 13 injections occurred in the cabotegravir arm, and 39 infections occurred in the Truvada arm. And so the incidence was much lower in the cabotegravir, the long-acting injectable arm, compared to the oral Truvada arm. I know Omar mentioned adherence and went a little bit into adherence, but what I want to say is that, adherence is always an issue when it comes to taking oral pills. And what this slide shows really is the reducing level of plasma tenofovir, which is used in this instance to measure adherence. You can see from the second column on your left, at the end of week 4, you had about 41.8% of persons were taking daily pills based on and this is based on the level of tenofovir in the plasma. But at the end of 81 weeks, you can see that this has reduced to 25.6%. And so similar to what we've been seeing with adherence generally as it relates to the HIV treatment. So adherence is an issue with oral Truvada. In terms of the injectable, in terms of the long-acting injectable, I know some persons have issues with receiving infection. And in fact, I think we have seen this played out in relation to the COVID-19 pandemic and the vaccines. But in this study, the injection site reaction for both arms were mostly mild. And you can see that it's a combination. The green part of the column are mild.
I'm sorry, someone's mic is on. Can you kindly check if your mic is on?
Because I have people that start March 1st, so they'll ask for she becoming to sign a contract.
Okay, Dr. Murray, thank you. So, so in terms of this study, the injection site reactions for both arms of the study were mostly mild. So the solid bar actually represents the arm that received the cabotegravir injection itself. And the other bar, sort of the striped bar, represent the arm that received Truvada but received a placebo injection. And you can see that the green and the orange represent mild and moderate adverse site reactions that included pain, tenderness, induration, itching, warmth, and so forth. But you can see that the majority of them were mild to moderate in terms of both arms of the study. So those receiving long-acting cabotegravir as well as those who received the placebo. And then finally on this study very quickly is that we have seen some increase in weight gain among persons who received injectable cabotegravir versus those who received Truvada. And so you can see cabotegravir, there was a plus 1.3 kg per year, whereas for Truvada, it was plus 0.3 kg. So some significance in terms of weight gain.
Morning.
In
Yes, ma'am.
cabotegravir. So in conclusion, in terms of long-acting injectable, in terms of long-acting injectable.
Tell me. Yes, ma'am. I think there's a book, it's an auto memorandum with nothing in honors. But I don't know why I don't think ministry sent it yet.
I believe you could mute it, Dr. Singh.
Yeah, all right.
It's
Mr. Marvin Otter.
All right, thank you. So in conclusion, as it relates to long-acting injectable, cabotegravir injectable was significantly superior to daily oral PrEP in reducing can see the comparison in terms of HIV incidence for cabotegravir, it's 0.41, and for daily oral Truvada, 1.22. Injection site reactions were typically mild to moderate, and in fact, they lasted between 4 to 2 days. Adherence, like I've shown on the separate slide, adherence waned in the TDF arm, and there was a greater median weight in the cabotegravir arm. And so we know that this long-acting injectable has been approved in the US. I think it was in December of last year, but it's a little over 2,600, I think, per treatment. The other, so continuing from that, the other study was the HP TN 084, and so it was PrEP with ARV agents that can reduce the risk of acquiring HIV, but it was focused on women. So women who have multiple barriers, and focused on women in sub-Saharan Africa. And so what was used was, again, the long-acting cabotegravir to see how women would have responded to that. And so this slide really is similar to the slide in terms of how the study was designed, and looking at the endpoints again. And so we can see from the HPTN 084 that was focused on women, that there were 4 new infections in the cabotegravir arm versus 36 new infections in the daily oral Truvada arm. And so the conclusion in terms of HPTN 084 is, again, that cabotegravir and Truvada, daily Truvada, are both highly effective for HIV prevention in cisgender women. We've seen in this study as well that adherence waned from 60% of participants taking daily oral Truvada at week 4 to 34% at week 57. The study also showed that cabotegravir is superior to daily oral Truvada for cisgender women. So there was an 8 and 9% lower risk of HIV infection for women in cabotegravir group versus the Truvada group. Similar weight increases were observed in both arms of the study, so that was not significant. Both agents were generally safe and well tolerated. No patient discontinued because of adverse events. And so based on HPTN 083 and 084, long-acting injectable cabotegravir was approved by the US FDA on December 20th, 2001. It's indicated for adults and adolescents weighing at least 35 kilograms. It is approved for cisgender. It is approved for cisgender and transgender men and women with no limitations whatsoever based on the type of sex that they have. A injectable cabotegravir has to be administered by a healthcare worker every 2 months, and that's seen sort of as one of the issue that could potentially arise in terms of service delivery. And in the US, the single PrEP injection will cost roughly $3,700, about the same as 2 months worth of whether you're using brand name Truvada or Descovy, But as you can see, it's significantly more than if we're to use generic Truvada, which we've been having the discussion on. So significantly more expensive, Descovy or injectable cabotegravir. I think there are some outstanding issues in terms of the long-acting injectable. So participants were all aged 18 and over. And so the question is, what are we thinking about in terms of our younger population? There is the need for information on acceptability and in many contexts, the feasibility of cabotegravir long-acting. We look at the prices just now, prohibitive, really expensive. And then on a more technical issue, cabotegravir long-acting cabotegravir has a long half-life, so there's a pharmacokinetic tail, and so it means that there's detectable drug that remains in the body after months of an injection, and small amounts can therefore lead to HIV drug resistance, and hence the recommendation to cover long-acting cabotegravir tail with Truvada for 1 year. And so how practical and how feasible this is also, and how desired it is, because if someone has been taking long-acting cabotegravir and then having to cover that cabotegravir tail with Truvada for an additional year, it's one of those outstanding issues that I think we have to talk about. In terms of the intravaginal ring, I'm going to move on here quickly. So it's a polymer ring that's inserted into the vagina and releases antiretroviral drug over time. And so there are a number of studies that are ongoing in terms of vaginal ring, but I think it's really pretty straight. Why rings? So there are no major safety concerns in terms of the rings. They're long acting, so they help with adherence. They're easy to use, they're private. They can be used inserted and removed in private, and they're rarely felt by partners, which is really very important as well. And they're effective against HIV. And so the questions that are being looked at right now is the ring, will the ring prevent HIV? Is the ring safe? Is the ring acceptable? And will women use the ring? So the whole question of adherence. And so there were a number of studies. There was the ring study, the Aspire study, and several others. So the Aspire study looked at randomized women 1-to-1 to a dapivirine ring arm and a placebo arm. And so women were counseled to wear the ring continuously, and a new ring was provided at scheduled monthly visits to the clinic, and follow-up was done 1 year later. And all of the women, whether they were in the intervention arm or the placebo arm, received comprehensive package of HIV prevention services. What the study did show is that overall, women who were in the dapivirine ring arm had a 20% reduction rate in HIV acquisition compared to the placebo arm. After excluding 2 sites, because there were sites that had lower adherence, the effectiveness of the ring in preventing HIV acquisition increased from 27% to 37%. So the Aspire study, therefore, when you look at adherence measures were statistically lower when the data was disaggregated, were statistically lower among 18 to 21-year-old compared to persons who were older than 21. And those persons who were older than 21 years old, because they had good adherence, they also had better protection against HIV. There were no difference in the frequency of safety endpoints between the 2-arm. Pregnancy incidence was quite similar. And there were mutations for those who seroconverted was similar in both arms. So 8 out of 68 persons and 10 out of 96 in the placebo arm. The second study in terms of the ring was the REACH study. And so this was a randomized open label crossover study. The first arm persons were given the dapivirine vaginal ring, and the other arm persons were put on daily oral Truvada. And at 6 months, a switch was made. So those who were on daily oral Truvada for PrEP were then given the vaginal ring, and those who were on the vaginal ring were crossed over to the daily oral Truvada. And so what the REACH study did is, so it was done at 5 sites. At 12 months, there were no drug-related adverse events and no adverse events related to any the product or any discontinuation. The most common adverse event included chlamydia, headache, and some amount of decreased creatinine clearance. In terms of acceptability, both options were acceptable. So the ring was acceptable at 85.5%. And the oral Truvada 63.9%. In terms of full compliance, and full compliance in this case was defined as for the ring, leaving the ring in place for a full month, and full compliance for oral Truvada was 6 tablets or more doses per week. And so for the ring, compliance was better, 50.2%. And for Truvada, this was just below 25%, which is comparatively really very low. In terms of the conclusion for the ring, Aspire, Ring, REACH, they've all shown that the piperine ring is effective in preventing HIV. It is a promising new option for HIV-1 prevention, but there has to be more tailored, there's a need for more tailored adherence support to increase adherence to the vaginal ring. The studies are still ongoing, and so there are some other studies. There's Enrich, there's Deliver, there's Protect that's working with breastfeeding women and pregnant women. So quite a few studies are still ongoing. And then the final part that I wanted to look at is the implant. And really it is a device implanted in the body that releases antiretroviral drugs over time. Sorry, this is not the final. I have one on the, and so this is ongoing. There are a number of initiatives. University of North Carolina has been awarded $2.9 million, for example, to work on a dolutegravir implant. Northwestern Medicine is working on a sustained long impact protection from HIV program, a SLAP program that's also developing implants. So there are a number of initiatives that are ongoing looking at implants. And then the final approach that I want to mention really quickly is the use of antibody, using what's called antibody binding prevention approach. And so the antibody mediated prevention, also known as HVPN, HPTN, HIV Prevention Trial 018, really tests an experimental antibody against HIV. So the AMP really is the antibody mediated prevention. And the idea is that giving people antibodies that fight HIV to see if this will protect them from acquiring HIV. So the first image that you can see on the left-hand side is without the antibodies. And so this facilitates, it allows HIV to bind to the cells. But when you take a look at a second image that has of a person who has antibodies, you can see that the antibodies actually prevents binding of the HIV virus. And so really in traditional HIV vaccine studies, people would get a vaccine and researchers will wait to see if their bodies will make antibodies against the HIV in response to the vaccine. When we take a look at antibody studies, you can see that we're actually skipping the step of giving a vaccine. We're actually skipping that step and introducing an antibody directly into the person. And so this is new frontier, and this is also under development. I will skip these slides, again, mindful of time, because I think Omar touched on them in his presentation. And so in summary, PrEP is safe. We've been talking about that over the last 2 days. PrEP is safe, PrEP is effective. There are more options that are available. Of course, we know in terms of efficacy, Truvada is still really, really good and high up on in terms of efficacy. It is affordable for us in the region. And so, but having said that, there are more options available, and there are more options that will probably become more available going forward. There is ongoing research on safety and efficacy, looking at more diverse populations, those cisgender populations and women. And of course, there is quite a bit of innovation that's happening right now. And so there's quite a lot of new frontier to look forward to. So long-acting injectable, implant, patches, antibodies, and so forth. And I will stop there. Thank you.
Thank you, Dr. Shanti. Colleagues, we are nearing the end of today's session. However, the floor is open for questions.
Pero tiene la presión en 190%. Ay, Dios.
Nurse Emiliana, do you have a question? Do you have a question?
Los nuevos estudios que están haciendo.
Okay, any questions from anyone?
I think Dr. Tran asked a question, which I'm curious as well.
Okay, let's see.
Okay, so my question was, how are the antibodies obtained?
Right. And so, Dr. Tran, so Dr. Tran, yeah. I can't give you the specifics. I don't know if I can get some assistance from Omar or Hortensia in terms of what I focus on is on the study, but the details of how it's obtained, it's not something that I've gone into. But I'm sure I can do the research, and maybe I can forward to you any additional information.
What is it? Sorry, can you repeat the question, Shanti, to me?
For the antibodies binding prevention initiative, how are the antibodies obtained?
Okay. Well, yeah, this is monoclonal antibodies. You know that one people every 3,000 people, more or less, are called elite controller or non-long-term progressor in HIV. So this is a very, very rare individuals that are infected with HIV. They have positive test, but doesn't receive treatment and are undetectable because the immune system is so strong that could avoid the HIV replication. This group of people were analyzed very well in order to see what is happening there, what part of the immune system is making this amazing result. And this is, so the researcher could identify specific antibodies that are called neutralizing antibodies. So are antibodies that really can neutralize the infection. So they took this antibody from these people, and with the genetic engineering, they could replicate this antibody. And this antibody are being produced outside of the bodies artificially through molecular genetic reengineering, and are then passed to by infusion to other individual. The process is a similar process that is being used for COVID, for example, that you have also antibody for Regeneron for treating the severe COVID in some parts. And so there are evidence that if you take this antibody, they produce in vitro outside of the patient and reinfuse to another individual, they can neutralize the infection or avoid the infection. what is seen now is that even though some individual can escape this antibody, so the virus can escape treated individuals. So the best place to use it now is prevention, because for treatment, the antibody need to be combined with other at least another 2 antibodies, or with drugs, because one antibody alone will be surpassed by the escape of the virus and the emergency of resistance to this antibody. I hope to be clear, but this is a research that is very preliminary yet. It's showing good results in prevention, probably for exposed children, and for it will be a good option also, because the children will not need to take sidobudin, and with this antibody, with this shot, can be prevented directly during the 6 months. So it's a field very active, very evolving, and we can share some review for those that are interested. Thank you, Shanti. Yeah.
Okay, thank you. I was wondering, because if it was actually just limited to either human production or even animal production as traditional vaccines, passive vaccination, that would limit the availability of
Yeah, you are
rolling
right.
it out.
It's very limited. The production process is very expensive. It's not doing it's not taken directly from the human. It's like the hepatitis B vaccine, it's recombinant generation. Also, they can simulate outside of the body the molecular structure, and they are producing it and putting it outside from the body. But this is very expensive and it's very time consuming. So the volume of production are very low. And so this will not be a standard treatment for everybody. And for the reason, they continue exploring implants and long-acting treatment that would be more easy to deploy.
Thank you.
Any additional questions before we move on to our final poll of the day?
A simple question, and that is there a regional report for the PrEP piloting? I know PrEP piloting occurred in Barbados, but is there a regional report that we can look at?
Sandra, maybe you have information, Sandra, if the Barbados will publish the experience on, we have access to. I don't know. I think that if Shanti, if the meeting with Barbados was recorded, the last PANCAP meeting where Barbados presented, maybe is a resource that we can share.
Right. If I could just add, and then perhaps Shanti could follow, is that we have tried, and unfortunately the person who was going to present had a family emergency, and so at the last minute that had to change. But I don't know if Shanti, if you have any ideas as to how we could get someone at this point in time to discuss their experiences. But one of the things both PANCAP and PAHO were trying to explore is to try to see how we could document the experiences from the different countries so that we could have that share across the board to other countries. I don't know, Shanti, do you know of any suggestions for tomorrow?
I know we have always worked with Dr. Ferbs in terms of sharing their experience in the Bahamas. I can check in with Dr. Forbes. I know that Guyana has made some progress. How much they have gone into implementation, I am not sure, but I can check on that and maybe send an email, Sandra.
Right.
I think Guyana and Bahamas, I'm not sure where else. I think Barbados is the most advanced in the region.
Exactly. The issue was trying to get a substitute at the late notice but I could try and see if there's someone could step in. Just in relation to the question, I think it was Caleb who asked, are we talking about from the standpoint of civil society or the Ministry of Health? Just so that we could be clear, because the presentation that was anticipated was going to include from the standpoint of civil society and would have included their coordination and collaboration with the Ministry of Health.
Well, clearly we need two standpoints, but I am more curious with the CSO because they have the reality on the ground. This, for the most part, clinicians just have to wait in their building and wait for somebody to show up for them to provide the diagnostic care. So yeah, civil society at this point.
Yeah, and I apologize, but because of the emergency, the person was not able to do it. I guess maybe Shanti, I could try and reach out to see if someone else can at this late stage, but when I had asked, the response was not a positive one, but we'll follow up and let you all know for tomorrow. Thanks.
Mhm.
Alrighty, Dr. Shanti, I'm going to pass it over to you for the final poll of the day.
So Cindy, I don't think we're doing a poll. I think what we want to do this afternoon is to get participants' feedback on any issue that they believe we should address, but we haven't done so. If there's something that's not clear that they'll need some clarification on and so forth. I am sending a link in the chat. If you click on the link, please, there's a link in the chat. If you click on the link, it will take you to a Padlet. Just go into the Padlet, and I'm going to put it up here so you can see. Click the link, you get onto the Padlet. On the right lower corner, you will see a pink circle with a plus sign. You click on that, and you're able to make your submission. So any questions, any outstanding issues, anything that needs clarification, if you can put that on the Padlet, our presenters will take those into considerations as much as possible and have those addressed before the training. If not, we can continue to work after the training as well.
Perfect. So once again, colleagues, the link is in the chat section.
There's a pink star right on the bottom right-hand corner, a circle with a star. You can see that your comments are anonymous, so don't be shy.
It's a pleasure. Thank you for choosing the reason. Well, thank you for visiting us. Thank you for the service.
So there are just two comments, unless everything was clear for day one and day two, and the presenters have answered all of the questions. We're looking forward to your feedback. So in addition to the poll that we had this morning, any specific issue that you may want to have addressed, we will take those into consideration and try our best to make sure that we can address them tomorrow and before the end of the training. If you don't want to, if you feel more comfortable, I should say, if you feel more comfortable typing in the chat, you can also type in the chat. Let us know what are some of the outstanding issues that you would want us to touch on. If something wasn't clear and we can maybe clarify tomorrow, spend some more time on clarifying, let us know. So you can type in the chat or you can type on the Padlet. It's anonymous, as you can see up on the screen.
All right, and while a few more persons leave their comments or questions, I will be inserting the link. We're using the same link for tomorrow's session. Someone had requested it, so I'm inserting that in the chat section of this application. Feel free to copy and use the same link for tomorrow. I want to say thank you all so much for joining us for day 2. Usually when we have 3-day events or trainings such as this one, participation tends to dwindle, and today we still have 55 participants, so that's very motivating. We're very grateful for your participation and your support. I hope you all have a wonderful rest of the day, and we're going to be here tomorrow again at 9 a.m. Thank you all.